أنا هبدأ أقدم حضرتك واسمح لي التقديم هيبقى باللغة العربية عشان ناخد حريتنا في الكلام، لأنه طبعا الدكتور رشاد برسوم مش محتاج تقديم، ويمكن أنا يعني من الناس القلائل في العالم كلهم لما يتقال الاسم هو خلاص الاسم، ودي حاجة بتبقى نعمة كبيرة جدا من ربنا. وطبعا ما جاتش بالحظ، اكيد جات يعني بمجهود رهيب جدا جدا جدا. ده كان سمارت سامري للسي في بتاع الدكتور رشاد، عمله الدكتور ايمن رفاعي في مارس 2018 لما كان بيقدمه عندنا في المركز، لما حضرتك زرت المركز في هذا التاريخ لتقييم طلب الدكتوراه الكلى اللي عاوزين يخشوا الامتحان. فما شاء الله 200 مقاله و2000 سايتيشن ورئاسه كوميتيز في كل مكان. فطبعا انا مش هقرا السي في لانه سي في معجز يعني. دولاب الجوائز يعني يعج بكل الجوائز الدوليه، الجامعه من امريكا ومن اوروبا من كل مكان. لكن احنا بما ان احنا مصريين، هي اعلى جائزه الواحد بيشرف بها حتى لو خد جوائز الدنيا هي جائزه النيل، لان هي اعلى قلاده او اعلى جائزه تمنحها جمهوريه مصر العربيه في البحث العلمي. فحضرتك خدتها في 2015، وطبعا كان قبلها ب5 سنوات جائزه دوله التقديريه. فطبعا ده حاجه مشرفه جدا. لكن نقول حاجه بسيطه كده. حضرتك الدكتور رشاد مواليد 41 في اسيوط، ويمكن الصوره ديت من اقدم الصور اللي انا حصلت عليها، طبعا جبتها من الدكتور طارق فياض. الصوره ديت ما اعرفش حضرتك كنت في الثانويه ولا كنت في طبعا، بس الصوره بتنم عن عبقريه بتولد يعني او بتنمو. الدكتوراه سنه 69، انا كنت مولود سنه 68. فطبعا تاريخ، وطبعا الاسره، الزوجه الدكتوره منى توفيق، صور في مراحل مختلفه من الحياه بتنم عن يعني ان حضرتك يعني بتتمتع بروح غير عاديه مع الابناء والاحفاد. واحنا معانا الدكتوره النهارده، معانا دكتوره نادين معانا على الزوم، واكيد هتشارك في الدسكشن. احب اقف عند الصوره دي. الصوره ديت انا مش عارف اذا كنت صح ولا لا. ده الدكتور باري برينر، صح؟
صح.
وده الدكتور شراير.
صح.
انا قابلت الدكتور باري برينر في هارفارد سنه 2008، يعني من 12 سنه. فعكسته في كلمه كان بيقولها كده، جمله كان ديسيجن بياخده. فقال لي انت منين؟ قلت له من مصر. فهو طبعا في مصر ما يعرفش غير الدكتور رشاد برسوم. قال لي انت شغال مع الدكتور رشاد برسوم؟ قلت له لا، انا شغال في مدينه المنصوره مع الدكتور ونيم والدكتور صبح. فطبعا ايه هو ده حضرتك يعني زيهم، يعني يمكن اعلى منهم. في 2012 دكتور طارق الباز اتشارجد مي في CME، وما كانش CME يبدا طبعا من غير وجود الدكتور رشاد ويبارك ويبدا ويشاركنا فيه. وزي ما حضرتك شايف كده الترحاب والبشاشه. الدكتور طارق كان رئيس الجمعيه، الدكتور خالد عويضه كان الامين العام، وحضرتك ده في مقر الجمعيه طبعا كان مع ميلاد CME اللي احنا بنتوسع فيه يوم عن اليوم. انا في صور طبعا حاططها سامبل. القاهره الدكتور هاني حافظ كنت اتمنى ان يبقى موجود، الدكتور علي طه، يعني كل الناس، الدكتور محمد صلاح، كل الناس، ومع الدكتور طبعا طارق. عين شمس السنه اللي فاتت وتكريم حضرتك عن استحقاق. طبعا حاطط الصوره دي عشان الدكتور طارق تنطوي معانا في الميتنج. الدكتور كمال عكاشه في ديسمبر الماضي لما استمتعنا بمحاضره حضرتك. علشان ما اطولش، حضرتك في المركز ده كانت سنه 2008، في يوليو 2008 لما حضرت معنا كورس كورونيك كيدني ديزيز، واديت فيه محاضره البانديمكس اوف CKD. وبعدها في 2009 بعدها بسنه حضرتك شرفتنا في الهيمودايلس كورس الثاني، وحضرت فيه جلسه الطلبه اللي اتحكمت في جامعه هارفارد. والحمد لله الكورس ايامها خد اكريديتيشن من هناك. فطبعا كان الدكتور احمد بيومي في هذا الوقت رئيس جامعه المنصوره، وطبعا التكريم عن استحقاق. حضرتك اثرت فينا جدا جدا لما دعيت حضرتك لتقييم كان الدكتوراه الكلى في جامعه المنصوره الا على مشارف دخول امتحان السكن. وانا قلت لهم الدكتور رشاد هيجي لكم بعد شهر للتقييم بحيث يتحطوا تحت رعب. طبعا هو يعني الناس الاجيال بقت مختلفه شويه، لكن كان يوم رائع جدا. الدكتوره سمر من جامعه قناه السويس، هي دلوقتي مدرس كلى في قناه السويس، قدمت قدام الدكتور رشاد الجزء من الرساله بتاعتها على الاوتوفاجي، والناس الثانيه قدموا. طبعا هنا الدكتور اشرف فوده والناس كتيره جدا والدكتور سمير وكثير من المركز، وحضرتك اديت محاضره الاوتوفاجي بعد السيشن، والدكتور ايمن رئيس الوحده. ودي كانت الصوره دايما بنشرف بحضرتك في المنصوره او في مصر او في اي مكان، وكانت قمه الدراما. يعني انا لا انسى فضل حضرتك تماما، والدكتوره سمر لما يكون حضرتك والدكتور صبحي بيناقشوها فقمتي الكلى واثنين جائزتي النيل، يعني حاجه كبيره جدا. لكن الاهم من ده ومن ده ان حضرتك في اليوم اللي مسافر فيه امريكا للعلاج جيت ناقشتها الصبح، وقليل من اللي بيعملوا الكلام ده، علشان حضرتك ما تتعطلش ولا يوم. وكانت فتحه خير لان بعدها اتجوزت وبقت مدرس كلى. وحضرتك بتناقش طبعا الدكتور اشرف بسط رئيس الجامعه، ودي كانت صوره المناقشه. فاحنا كلنا الكانديديت، واحنا كلنا الدكتور صبحي اللي هو استاذي الكبير جدا 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 قال لي ان الدكتور رشاد من احد اساتذتي. يعني انا يعني بعتز بثلاث اساتذه، الدكتور زكي شعير، الدكتور محمد غنيم، والدكتور رشاد برسوم. هنا دي صوره برضو مع الجروب بتاعتنا في المنصوره. مش عاوز اطول على حضرتك، اللي حضرتك علمتنا ازاي نتكلم وازاي نعمل محاضرات، وحضرتك فعلا الموهبه تمشي على الارض وكل الناس بتتعلم. فده كان محاضره دايابيزيتي اللي كانت في ديسمبر، اخر محاضره طويله حضرتك قلتها. وبعدين حضرتك فاجئتنا في يوم 29 ابريل 2020 ان حضرتك عملت فريق لحط الاميون سبريشن في رينال ترانسبلانتيشن على قواعد كومباتبل تماما 100% تقريبا مع الكيديو جايد لاينز. حضرتك الفيديو انا حاطط صوره منه علشان الناس تشوف مراجعه بس التكست 3 ساعات ونص كونتينيوس. دكتور رشاد بيعلمنا هاو تو ريد اند هاو تو رايت. انا متاكد ان النهارده هيبقى فعلا لقاء، وده بدايه سلسله ميت ذا اكسبيرت اونلاين. وحضرتك حددت التوبيك اللي هنتكلم فيه. حضرتك هتبدا المحاضره، وانا متاكد ان الناس كلها مستنيه المحاضره بفارغ الصبر. وبشكرك يعني ان حضرتك اديت لنا الوقت ده، وطبعا نتمنى للجميع الفايده من وجود سعادتك. حضرتك تقدر تعمل شير الوقت البرزنتيشن يا باشا.
عايز بس أشكرك جدا يا حسين على التقديم الجميل ده. رجعني سنين طويلة ورا لذكريات كلها جميلة. كل ذكرياتي مع المنصورة جميلة دايما، لحبي وليهم وحبهم ليا. في الحقيقة أنا يعني سعيد الحظ إني أعرف فريق رائع زي فريق المنصورة، وشخص رائع زيك الحقيقة يستحق كل احترام وتقدير، فبشكرك قوي عليه.
يا باشا العفو. واحنا يكفي ان النهارده معانا الدكتور نبيل، صح مش في المنصوره دلوقتي، هو من فريق المنصوره الاوائل، بس هو في
طبعا.
السعوديه. اول يوم يخش، اول مره يخش على الزوم معانا. فده معناها ان حضرتك لك مكانه عاليه جدا 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 في قلوبنا جميعا. اتفضل اتفضل يا باشا. تقدر تعمل شير حضرتك دلوقتي.
كده كويس؟
كده كويس. حضرتك اعمل بس اوبن على الداتا شو على التلفزيون من تحت.
ابقى اوبن وات كله مفتوح؟ ها في حاجه مقفوله؟
لا حضرتك اضغط على الشو بحيث يفتح سلايد شو.
طبعا هعمل كده، لكن السكه ماشيه
كويس زي الفل. مبين العنوان وكل حاجه تمام.
اوكي
زي الفل يا باشا. اتفضل.
topic chosen for me with Professor Hussein is on COVID-19 and the kidney. I shall try within the coming 30 minutes or so to convince you that the team taking care of COVID patients should include a nephrologist, owing to the very significant involvement of the kidney, which is not generally perceived among the general the public or even with the medical profession. It is entirely a new issue that will include in my speech 3 major issues: the epidemiology of kidney disease in COVID, the pathogenesis of the kidney disorder that happens in these patients, and touch on management on how to deal with the kidney involvement in this disease. The story starts, if you look into this publication, it was submitted for publication from China on the 5th of March. As you know, COVID was announced as a pandemic on the 11th of March, so only a week before the announcement of the WHO. The publication comes from Wuhan by a group led by Ching, who reported on 701 patients. This is perhaps the most often cited publication about kidney involvement in COVID disease coming from China. They reported in these patients about 14% elevated serum creatinine, 13% BUN, 13% GFR below 60. About half of the patient had proteinuria, and 1/4 had hematuria, and 5% had classic acute kidney injury, according to the most recent KDIGO guideline definitions. They also reported on mortality in these patients. And you can see here the mortality, percents of mortality in different, according to different parameters. You see that acute kidney injury was associated with about 75% mortality, very high. 3/4 of the patients died with acute kidney injury. Serum creatinine had the same impact. Baseline creatinine on admission had an impact, so that if the patient was admitted to the hospital with a high creatinine, he had a higher mortality than those with normal creatinine. BUN was even worse because it indicates that the patients were very catabolic, probably very anuric, so the baseline BUN was significant. Hematuria and proteinuria had a 50% mortality. So you can see that in the very first publication about kidney disease in COVID, there was an extremely alarming mortality rate, whether you have an acute kidney disease or failure, both had a very high mortality. Ironically, a week later, on the 11th of March, 1 week later, just on the same day that the WHO announced it as a pandemic, another paper coming again from Wuhan had this title: does not result in acute kidney injury. So China introduced the disease and denied it in 1 week, which is very ironic, in fact. So the challenge is to see which was right, because you really cannot take both as reliable references. So I looked into references coming from all parts of the world, and I think they support, clearly support the initial Cheng report that AKI does happen and acute kidney disease happens in patients with COVID. So we will disregard this publication. You see, it's based on 116 patients. The other one is 700 patients. So probably these patients were lucky enough not to be detected. The other group was a nephrology group. This is an infectious disease group. So probably their interest in kidney was not very marked. So these are some explanations why there was this remarkable conflict in China, whether kidney disease is part of COVID or not. This is a very interesting meta-analysis that was produced in England by the Royal College of Physicians, comparing 5,000 patients who had pneumonia due to COVID and another 5,000 patients or plus without COVID, having pneumonia without COVID. In both, there was an increase in mortality. So in the COVID group, for instance, the mortality was 38% in advanced life support by respiratory. If they had a kidney involvement, there was no significant change in mortality. But look at those who died. There was a significant impact of having kidney and lung involved in COVID. But that was very significantly higher than pneumonias due to other causes. So pneumonia increases mortality. Kidney disease on top of pneumonia further increases mortality. But when this is due to COVID, the mortality becomes again 75%, exactly the same figure that was published in China by Cheng et al. So the United Kingdom supported the first publication coming from China. The numbers were different from other parts of the world. So acute kidney injury was reported from 5% to 75%, but the usual figure that you expect from any publication about kidney involvement, AKI, kidney injury, is about 25%, 20 to 30. The figure was lower in Montreal, 8%, Pittsburgh 33, London 35, Ghent, Belgium 72. So there is a remarkable difference, I think, is related to the definition of AKI, because not all of these publications actually mentioned the stage of AKI or abided by a particular classification of AKI. So probably what we need in the future is to look more into the stage when people report on AKI. The need for renal replacement therapy in these KI patients were also 20 to 35% of patients. That is to say that about 2/3 of patients will not need dialysis. And the mortality was as high as mentioned in China. So this slide alone shows you that we are talking about a serious complication of COVID that really necessitates the intervention of nephrologists in those patients. And that is a series of pathology slides that were reported from different parts of the world about the kidney lesions that you can see in those patients, varying from this proximal tubular lesion, which is very common. It's not very specific, but very highly suggestive. Kidney tubules full of vacuoles, sort of foam cells, with very little interstitial infiltration and no increase in volume. And that is what we call isometric vacuolation of the proximal convoluted tubules. You will also notice that there is no brush border. The brush border is one of the earliest stages to be involved. So you can see this lesion, when you see it, you really suspect COVID. But also you see this an artery with intimal infiltration with round cells. So endotheliitis of the vessel is very typical as well. There is interstitial edema in some patients and interstitial fiber infiltration in others. You see here a glomerulus that is collapsed. So collapsing glomerulopathy is one of the lesions that have been described. You can see thrombosis in capillaries at the entry of the glomerulus in these two vessels that are occluded. You can see debris of tubule cells that are desquamated and they fall into the lumen of the tubule. So a widespread range of lesions that are mostly interstitial and collapsing glomerulopathy with capillary thrombi, which in fact reflects exactly what COVID does in other organs. The lung has very similar appearances, but at a pulmonary level. The thrombosis, the collapse, the interstitial infiltration, the vascular disease, and so on. So it is a truth, it is a reality that you do have what we can call COVID-19 nephropathy expressed by all these kinds of lesions. When you address patients with chronic kidney disease, this is the usual iceberg that every nephrologist knows, that patients can have a kidney disease starting from stage 1. This is hidden, you don't see anything, and 2, and many patients with stage 3, until you go to stage 4 CKD, that you start to see some symptoms and signs. Others are detected only by lab findings and so on. And stage 5, where the creatinine clearance, eGFR, is less than 15. These are the patients who eventually need dialysis or transplantation. So we normally work on this category of patients. Some nephrologists would see these patients, and the rest are usually hidden. Now, what happens when any of these patients gets COVID? If it happens in stages 1 or 2, there is no problem. The same risk as the general population, but please remember that stages 1 and 2 include diabetics, they include hypertensive, they include old age. So there are other comorbid conditions with stages 1 and 2 that can be risk factors for COVID as well. But when you get COVID in stages 3 or 4, you start to go into trouble. And here is a meta-analysis of 4 studies that address this population of patients with chronic kidney disease, and it shows that the relative risk of mortality is about triple, 3-folds of death compared to the general population. If you have 5% mortality in the general population, it becomes 15 in the same country, in the same environment, if they have moderate impairment of kidney function. Those on dialysis have a chance of a 1% incidence of COVID infection every month. This is a study that shows 2% in 2 months. So 1% a month is the usual. If you stay in the epidemic for 2 years, you will have 1/4 of your patients getting COVID somehow. There are lots of comorbidities in these patients. Again, diabetes, hypertension, but add to them the non-traditional factors of risk, including the calcium, the phosphate, the potassium, the parathyroid, and all these things. So these patients have an added risk of dying, and the mortality in those patients has been reported between 30 and 50%. 1/3 to 1/5 of patients on dialysis who get COVID will die. So it is serious, and we have to protect our patients very much from that by special measures that I'll have no time to discuss, but I'll just allude to them at the end. Transplantation. New transplants have been stopped almost all over the world at the beginning. Some transplant centers are returning back to their normal activity. And Professor Hussein told me that there will be a webinar in the near future to discuss particularly whether we should continue stopping transplants or starting. First, there is a living donor risk. If you admit a normal individual to the hospital to take a kidney out for a transplantation, you expose him to infection and to a surgical wound and so on in an environment that may be a bit too infectious for him or her. Deceased donors are an issue. First, the harvesting system has been interrupted by COVID. So here is, for example, the Spanish experience, where the donor kidneys dropped, the harvesting, the collection of kidneys from cadaver dropped from 7.2 to 1.2 per day. Spain, as you know, is the most busy country doing cadaver transplants, so down to 1/6. And the actual transplants, not the harvesting, dropped from 16 to 2 per day. And there are similar data, national data from France, showing how much the rate of transplantation has dropped in inverse proportion to the spread of COVID. And national registry from the United States also showing a remarkable drop. So all over the world, the activity of kidney transplantation has been arrested except for emergencies, both due to harvesting and due to inavailability of living donors. So that was a hit, a big hit to transplant everywhere. The recipient's risk, of course, is higher because you get an individual who is on dialysis or at least in advanced chronic kidney disease with impaired immunity, and you take them to the hospital, do a transplant, and immunosuppress them massively by corticosteroids and high doses of immunosuppressive agents in an environment of COVID. So eventually you may actually end up with a successful transplant, but a dead patient. That's why everybody stopped transplantation for this era. But if a patient has been transplanted earlier on and gets an infection, which is not very common, this is the frequency, 3 per 1,000, but it happens during the first 3 months, if it ever happens, up to 6.2%, many folds in the first few months. The severity, more than half of the patients require ICU admission, so it is a severe disease. You have to modify immunosuppression in those patients. So CellCept MMF in particular has to be stopped. I think the general tendency is not to stop Sandimmune or other CNIs because they may have some antiviral effect and apparently they are helpful, but that does not mean that we should treat patients with this, but we only reduce steroids and CellCept. If you reduce too much, the patient goes into acute rejection. You have to treat the acute rejection by massive doses of steroids. So you in trial to reduce the chances of spreading the infection, you spread it more by exposing the patient to an acute rejection. Mortality varied from 14% in England to about 2/3 of patients with transplantation who got this disease died in Iran. And these are the references for those who are interested in these data. So far for the epidemiology of this condition. And now we move on to the pathogenesis, which will take most of my talk this evening. The kidney is a very robust structure. It can stand a lot of injuries. And normally you need at least 2 injuries to get acute kidney injury. But in COVID, you get all these levels of injury. You have the effect of systemic hemodynamic derangement, shock, dehydration, sepsis, and so on. You have a very specific role of angiotensin II, which I'm going to elaborate on because of the mutual admiration between COVID and ACE2 receptors. So that leads to tissue injury. There is the issue of cytokines that may be mild or severe, with the cytokine storm inducing a massive systemic inflammatory response. There is endothelial damage that can lead to thrombotic microangiopathy and provoke thrombosis. And there is a direct viral invasion of the kidney tissue, leading to nephron damage that supervenes both with the endothelial damage and with the direct viral invasion. Let us look into each of these separately, but I want to remind you that all of them may be present in the same patient, and they are not necessarily sequential, because you can have a patient without systemic hemodynamic effects that have a direct viral invasion. You can have a mild cytokine storm, but you have a severe impairment of the angiotensin system. So there can be variabilities, quantitative, in between these different stages, although eventually patients who are going to die will probably have all of them operating at the same time. The systemic hemodynamic derangement doesn't need a lot of discussion. There is fluid loss because of the fever, and some patients who have got diarrhea or vomiting or tachypnea, they lose fluid. So they come to the hospital with massive fluid loss. And the trouble is, if you try to replenish these fluids and start to hydrate them as you do in the ICU, the lung is already damaged enough. So you very readily get a pulmonary edema. So you find yourself in between the risk of continued dehydration or overhydration, and you have to be extremely careful in doing the fluid loss under careful monitoring of all the parameters of fluid hydration. Cardiac output is low because the blood volume is low, but also because the myocardium is one of the targets, and many patients would have also myocarditis with a low cardiac output and therefore impaired renal blood flow. Compartmentalization due to the sepsis or even without sepsis. For instance, if you get pulmonary or renal vein thrombosis, which happens in many of these patients, you have fluid sequestrated in certain space, and you have some edema in patients with sepsis and so on. So you lose fluid inside you. There is the intra-abdominal hypertension due to all the factors that we know about it. And many patients would get secondary sepsis. Many patients with pulmonary involvement with COVID eventually got bacterial infection or fungal infection, and they go also into the composite picture of secondary sepsis. So all that contributes to the acute kidney injury. Angiotensin story is a fascinating story because I remind ourselves first with the angiotensinogen system that becomes extremely deranged in COVID. You know that you have angiotensinogen produced by the liver that circulates and goes to the lung in particular, where and other tissues, kidneys included, to produce angiotensin 1. Angiotensin 1 is a decapeptide, 10 amino acids. This is the arrangement, which is the target of angiotensin converting enzyme, which is mainly produced in the lung. Please remember that this next step occurs in the lung. So by ACE, you remove 2 amino acids and you produce an octapeptide, only 8 amino acids instead of 10. And this angiotensin 2 has these pharmacological effects: vasoconstriction, salt and water retention, cell proliferation, reactive oxygen molecules, fibrosis, and inflammation. A very harmful molecule if it accumulates in any tissue. And the tissue here is lung. And I'm going to show you later that it also kidney, because angiotensin 2 has the same effects on the kidney as it has in the lung. But fortunately, we also have another angiotensin converting enzyme that was discovered much more recently, in year 2000 approximately, which is called ACE2. ACE2 has the capacity of severing another molecule. Instead of having 8 amino acids, you get 7 amino acids, and you call it angiotensin 1,7, from 1 to 7. Angiotensin 7 is a blessing. It's the buffer that has these effects: vasodilatation, diuresis, natriuresis, anti-proliferation, antioxidant, increased nitric oxide and bradykinin, and reduced renal injury. So this angiotensin 1,7 is a protection from the harmful effects of angiotensin 2 itself. And that balance is extremely important in keeping tissues protected from the potential of damage happening by angiotensin II. You need angiotensin 1-7. And because you need it, it can happen through a different alternative pathway like this. Angiotensin 1, 10 amino acids. Angiotensin 2 can start the story. But the capacity of angiotensin 2 to sever an amino acid is only 1. So you remove one of the 10, you get angiotensin 1-9. And that now becomes subject to action by ACE to remove 2 amino acids, as it has done earlier on, and you get 1-7. So you get angiotensin 1-7 either through a classical pathway like this or an alternative pathway like this. The axis 1-9, 1-7, and ACE2 is a protective axis that has been confirmed to be very useful in heart patients. Cardiologists know very well how much friendly ACE2, angiotensin 1-9, and angiotensin 1-7 are important for cardiac function and remodeling. It's important to remember this because ACE2 is the target of COVID. ACE2 is the target of COVID, and therefore it defines which tissues are going to be affected by this COVID infection. As I mentioned, ACE2 is a protection that God has given us against ACE effects. And therefore, the ratio between ACE2 and ACE is important in different tissues. And I'm going to focus on 3 important tissues. The lung, where you have ACE much more than ACE2, 20-1. 20-1. That is to say, the lung is exposed very much to ACE and needs this little amount of ACE2 to remain protected, as I'm going to show you now in a minute. Protected from what? From the injury of ACE1. And if the virus affects the ACE2 of the lung, you leave ACE unchecked, and therefore the lung becomes a target of massive injury. The heart is a tissue that has the reverse, more ACE2 as compared to ACE1. It doesn't generate ACE anyway, and has a lot of ACE2, as I mentioned. The cardiologists love it. It has a lot of 1-7 and a lot of 1-9. So ACE2 is the dominant ACE in the heart muscle. The kidney, our friend, is equal. You have ACE2 and ACE in equal proportions, 1-1. 20-1 in the lung, 1-20 in the heart, and 1-1 in the kidney. If you look into kidney tissue, and look here, this is ACE. It can be stained around the tubules, as you can see here. The glomerulus has got some ACE, but not as dense as the tubules. This is ACE2, and this is the overlap picture showing that exactly the same points. When there is ACE, there is also ACE2 to try and protect the kidney from the damage produced by ACE. Ironically, diabetic patients lose ACE2, and they are exposed to only ACE1. Here is nothing in the glomerulus, ACE1 around the tubules, very low ACE2, and when you overlap, it's mostly ACE in the lung. So one of the damage that happens in the kidney due to derangement of this system is due to loss of ACE2, which is a nephroprotective molecule. Now, this is the virus, as everybody knows. The dangerous part is the spike. And the spike, as you can see, is composed of a sort of a thick area like this called S1, the spike 1 protein, and a narrow part called the S2, which is the second part of the spike protein. But look at this cleft in between S1 and S2. The cleft. There is the cleft. And the cleft has got affinity to the virus. If you look at this in larger magnification and see the virus, here is the S1, and this is S2, and this is the cleft in between S1 and S2. It has got the receptor binding motif, which is within the receptor binding domain. So receptor for what? For ACE2. The virus is prepared to insert ACE2 into this cleft through attachment of this molecule of the receptor binding motif in the receptor binding domain. This is how the S protein of the virus looks like by crystal structure. The domain is this, and the motif here is red. And now S2 gets attached this way. It fits very well into the motif and gets attached by certain links here, and you make a big complex here of the ACE2 molecule and the virus through its spike to make this big structure that is extremely firm. It's extremely firm. Once they attach, they don't detach anymore. The story starts with the bat. The bat is fond of flying, as you know, and spends a lot of energy in flying, and during doing that, it regenerates tissues and produces some abundant nucleic acid residues, including viruses. So the bat actually is a factory of viruses. It produces RNAs and DNAs, which are not involved in the process of regeneration of the virus, of the bat's tissue. And therefore, the bat is full of viruses, although it has a very strong immune system that doesn't make it ill with the viruses, but it becomes a reservoir of viruses, which change with time. They change with time by mutations, and the bat is okay until it finds an animal, an intermediate host, and that is the pangolin, which was the first animal. It lives in the deserts of Southeast Asia, that first gets infected with the bat's viruses, including COVID. And COVID stays in this until it finds the definitive host, which is human. But recently, we understood that the pangolin is not the only animal, or perhaps not even the animal that is responsible for the current episode. It's another animal, very much like a cat, called the civet. It has a special smell, which is used to produce the musk in the perfumes that we use, our ladies and men, in our day-to-day life. The civet turns out to be the intermediate host that could host the COVID virus. And in the civet, it underwent a mutation. It changed the mutation, the virus itself, to fit with the civet ACE2. So this is how ACE2 of the civet attaches itself to the motif of the virus in civet2. Humans have got a different ACE2. So this is the human ACE2, and that is the modification that happened in the virus to fit the human ACE2. And when these two things happened, when humans have evolved into this structure of their ACE2, and the virus also evolved to become fitting with the ACE2 of the human, it became human pathogenic, and we got the pandemic of 2019. The interaction between the virus and ACE2, as I mentioned, must depend on how much ACE2 you have got, because it just loves it. And that is the concentration of ACE2 in different tissues in the body. And what I'm going to show you here are certain interesting tissues. First, of course, the lung, that has got a moderate amount of ACE2, as I mentioned, much less than ACE. And here is the heart and kidney that have got a lot. I want to show you the intestine. The intestine is the colon, as colon is here, intestine is here. They are very rich in ACE2, and therefore they are, the enterocytes in general, are very susceptible to the effect of the virus, which explains why some patients with COVID-19 develop diarrhea and vomiting and GI manifestations rather than lung disease. This has been described in Japan a lot, and we see it much more these days in our country. We see patients who just get the diarrhea and are positive for corona without having any lung disorder or very minimal lung disorder. And we also know that many patients with COVID don't have any CT findings at all, although they do have COVID, because other tissues can get infected, as you can see here. I want to go a little bit further into this area by showing you how exactly this interaction happens. This is the cell membrane. ACE2, as you know, is attached to tissues. The amount circulating in the blood is very low. So it's not like ACE circulating in the blood, it is in the tissues. and this is standing there waiting for the virus. Now here the virus comes, and both of them have to be activated in order to attach. And that happens through a transmembrane protease, SS2, which is called transmembrane protease, TMP, SS2. That has got dual actions. It unfolds the spike protein and also opens up the attachment point in the ACE. In the presence of TMP SS2, you can have this attachment happening and the virus links into the receptor as I showed. But there is a scavenger that can stop this process, which is ADAM17. There are many ADAMs, as you know. We are all familiar with ADAM13 that is involved in the hemolytic uremic syndrome. It's A, the ADAM A, disintegrine, and metalloproteinase 17. And that dislodges this. So the balance happens between TMPR SS2 and ADAM17 in defining how much of ACE2 is consumed by the virus. I say consumed because once this happens, they both are integrated and go into the tissues. And let us compare what happens in the lung with what happens in the kidney. Here is the lung. You go into the virus comes into the alveolus, where two important cells meet it. The type 2 alveolar cells, which secrete pulmonary surfactant, and on the surface of this, you have a lot of ACE2. So the virus meets ACE2 and goes into this cell. Look at this cell and compare it with the endothelial cell, with the normal type 1 alveolar cells. You can note here the organelles in the cell. There is a big nucleus, there is a Golgi apparatus, there is an endoplasmic reticulum, a full machinery which the virus needs in order to produce itself, reproduce itself. And therefore, the virus doesn't like alveolar cells type 1. There is no machinery. It loves this because it's going to salvage this and use it to produce more virus. So it comes here to live and to reproduce and to reshed. But it also comes to the alveolar macrophages, which are immune cells. There are toll-like receptors here, which will take the virus and infuse an immune response. Once the virus is in the alveolus, it doesn't like very much the smooth cells here. It loves this cell and is attacked by this cell. And that is the balance that happens there and decides how much pneumonia you get at the end of the day. Mind you that this cell secretes surfactant. When it becomes very busy in reproducing the virus, it stops producing surfactant, which is important to keep the alveolus patent. And once you lose surfactant, the alveolus collapses. And therefore, atelectasis is a very early feature. And air becomes much less in the lung due to collapse of the alveolus, and that gives the ground glass appearance that you see in the X-ray. But as virus grows here, it starts to be shed everywhere and goes to the pulmonary capillaries, and that allows it to disseminate to the rest of the body and goes to other tissues which have got ACE2. The kidney has a very interestingly similar structure. There is a capillary lumen. This is the capillary cell, and there is here the podocyte, the visceral podocyte, which is a machinery very much like this cell, and there is a mesangial cell, which is very much like a toll-like receptor-containing cell. So again, the virus finding itself in the lumen of the capillary has the immune cell and has the machinery to grow. If you search for the virus, you will find it mostly in the podocyte, but also you have a hypertrophy of the mesangial cells, and you also find it in the tubule cells. There is a lot of ACE in the brush border of the tubule cell, and therefore the virus attaches here and goes into the cell, uses the machinery to produce more virus. Very much like the lung by different names, as you can see. Now, the virus attaches itself to ACE2, and they are both taken inside the cell by a process of endocytosis, the receptor as this virus. And that leads, of course, to the whole cycle of the virus clearance. But look at what happens to ACE. ACE is depleted ACE2 goes into the cell instead of staying at the surface. So its function as an antagonist to angiotensin 2 is blocked. And therefore, you don't have enough ACE at the surface of the lung or in the kidney. And depletion of ACE2 will leave angiotensin 1 and angiotensin 2 unantagonized. That is the story of ACE. الوقت ماشي يا حسين ولا خلصت ولا ايه؟ Am I okay? مش سامع.
You are okay, even if you stay with us for hours. It is very fine. Fantastic presentation.
If you like to break, I can break at any point.
No. I enjoyed.
But I thought this is the opportunity to show why the kidney is involved.
I enjoyed the pathophysiology very much because it explains a lot for the mystery of presentation of this virus. Thank you very much, Professor Rashad.
Thank you. So then we see the story of angiotensin 2, and then comes the role of cytokines. The cytokines are produced, as you know, from the classical immune system. Here is the tolerase receptor I told you about, which is present in the macrophage of the alveolus and also in the mesangial cell of the kidney. It takes the virus inside, it processes it and handles it to the T lymphocyte and then to the B lymphocyte. And the B lymphocyte also has the same capacity, and it handles the virus to the T lymphocyte, which produces all these cytokines. A very classical innate immunity pathway. Of course, we know that other pathways are involved, but I will focus on this because this is the responsible thing for the cytokine storm, which is composed mostly of these four: interferon gamma, interleukin 1, which is responsible for the fever, TNF alpha, which is responsible for the vascular manifestations, the shock and hypotension, and interleukin 6, which sustains this cytokine syndrome, and it grows on higher and higher until you get the classical syndrome. Not much to say apart from that the cytokines include inflammation, and it also includes rhabdomyolysis, which adds to the kidney injury. Endothelial damage is the outcome of all that, of complement activation, of cytokine effects, of angiotensin effects. So you have damage of the endothelium, which leads to TMA, thrombotic microangiopathy, and the tissue injury is responsible, together with the inflammation and the rhabdomyolysis, to disseminated intravascular coagulation. So we have the clotting phenomena that we see in patients with COVID. And that happens in all tissues with this very famous organ, crosstalk, in these patients. The lung is injured, the kidney is injured, the heart is injured by the virus. Look at what happens when you get virus affecting the lung. You get pneumonia and thrombosis, and that leads to hypoxia, and hypoxia leads to medullary kidney hypoxia, which is bad for the integrity of the tubules. And when the kidney is in acute kidney injury, retain salt and water, you get congestion. Myocarditis is one of the outcomes of cytokine effects on the heart. Hypotension occurs due to low cardiac output. Renal compartmentalization occurs when you have renal vein thrombosis. And the kidney failure leads to retention of middle molecules and so on, and you get systolic hypotension in the heart. And finally, the virus affects the kidney directly. So all the organs talk together, and not unexpectedly, you get a syndrome of failure, multi-system failure that you see in those patients. Now, as I mentioned, there is a direct viral invasion that occurs. And here is a larger magnification of what you have seen earlier, which is the proximal tubule, lots of vacuoles. These are proteosomes, all of them. And the vacuoles do not increase the size, it's isometric vacuolation. And if you see this in a larger magnification and even a larger magnification, you'll be surprised. Here is the virus. The virus actually lives in the proteosomes here. The virus is here with the spikes, as you can see. You can see all these clumps of virus are living in the proximal convolute tubules. And in the glomerulus, they affect the podocyte. And as you know, the podocyte injury leads to collapse of the glomerulus. And you get a form of focal segmental sclerosis known as collapsing glomerulopathy, which happens in other virus infections. It occurs in hepatitis C, occurs in HIV. So this is another virus that is added to the list, which causes collapsing glomerulopathy. Larger magnification, again, showing these are the food processes, the podocyte, and this clump in the urinary space and in the body of the podocyte. Larger magnification shows the virus, again, living inside the podocyte. So we have conclusive evidence that COVID-V2 virus lives in the kidney, replicates in the kidney, and can cause kidney damage by all the mechanisms that I have shown. Now I can sum up with a very quick review of the specific management lines that will not take more than 5 minutes, Mr. Chairman. Here is the pyramid of the pathogenesis that we have just described. The targets, of course, in stage 1, which is the systemic hemodynamic change, is fluid therapy, careful about pulmonary edema, vasopressors, because the peripheral circulation may be compromised, so you have to maintain the peripheral resistance by vasopressin, and antibiotics when you have secondary sepsis. A very useful parameter here is to check either for cultures or by pre-albumin measurement, procalcitonin. Angiotensin 2 raises the issue whether we should continue or stop ARBs treatment and ACE inhibitors, because most of these patients are already diabetic or hypertensive and are receiving ACE inhibitors or ARBs. This is what I have shown earlier on. I just want to show you that when you inhibit ACE, what happens is you reduce angiotensin 2, you raise ACE2, you increase angiotensin 1,7, and you have this nice effect of vasodilatation, diuresis, and all that. So ACE inhibitor treatment for these patients is justified because it helps, okay? You also generate bradykinin, which is normally split by ACE. If this doesn't happen, you have more bradykinin and more TPA, which is useful. It dissolves clots and is. So the ambience in patients who are diabetic or hypertensive receiving ACE inhibitors is very favorable from every point of view, to the heart, to the lung, to the kidney, and everything. And those who are receiving an ARB, similar things happen in a different way. You stop the receptor, you accumulate angiotensin 2, and therefore you activate A2 receptor, which is favorable. You increase ACE2, you increase angiotensin 1,7, and you activate the MAS2 receptor, which is the specific receptor for angiotensin 1,7, and all that is favorable. So you also have increased ACE2. So these patients who are receiving ACE or ARBs are living in a status that is favorable for their health. But the problem is that as you increase ACE2, you increase the affinity to the virus because it loves ACE2, as I have explained. So we are now put in a very difficult choice. Shall we stop ACE inhibitors and ARBs in order to reduce the number of ACE2 receptors and inhibit the growth and invasion of the virus, and deprive the patient of the benefits of ACE2 and ACE angiotensin receptor blockers, or continue? The debate continues, but the WHO recommendations are clear and CDC recommendations are clear. Those who are on ACE or ARB treatment should continue. Don't stop them, because the benefit seems to be much more. And if you stop them in the hope that the virus will not invade their tissues, they will die of strokes and heart failures and so on. So keep them. But those who are not on ACE or ARBs, you don't start them if they are in an episode of corona. There is a very promising treatment modality here, which is the recombinant ACE2 that has been actually tried on humans. And that seems to be a very promising, but that can help in corona, as well as in non-corona situations, as I mentioned, for instance, in diabetic patients with kidney disease. If you can provide them with ACE2 and make sure that you put the right vector that inserts them on the cell surfaces, it can be a revolutionary treatment for conditions where ACE2 is deficient. The issue of cytokine treatment. Of course, there are issues about hydroxychloroquine, which has a very nice rationale theoretically. A, It inhibits antigen processing by the toll-like receptors. It inhibits B cell processing as well, so the viral protein is not processed. It inhibits autophagy, so cell debris accumulate in these tissues, so the cytokine production is decreased. And it also has other effects on the viral replication itself, as I'm going to show you in a minute. So in theory, hydroxychloroquine has strong rationale. It has been tried with SARS and has been tried with the Middle East epidemic that happened later on, the MERS. But it works with animal models, but it never proved effective in human experiments. What happened with hydroxyquinine is a big row generated by the President of the United States, but also followed by many trials that have been done by prophylaxis in England, by treatment in France, by treatment in many centers all over the world, by controlled trials. But the result has never been confirmed. And the most recent outcome that came up in the New England Journal of Medicine very recently, about 2 weeks ago, was an observational study with a large number of patients that has shown absolutely no difference. If anything, slightly worse results in patients who used hydroxychloroquine because of the cardiac effects. And it was stopped in Sweden because of the eye effects. So eventually, the current status is, despite a very strong theoretical rationale and reasonably strong animal model findings, there is no human evidence that hydroxychloroquine helps. Interleukin-6, as you know, the cytokine storm is what kills people at the end of the day. So if you can stop it, and you can stop the sustainable thing in this, which is interleukin-6, using this in patients with the cytokine storm can save lives, and it did save lives. And extracorporeal therapy by using high flux membranes or hemodiafiltration with high flux may remove cytokines, as we know. But the problem is that when you remove cytokines like interleukin-6, you also remove modulatory cytokines like interleukin-10. And you never control the balance between interleukin-6 and interleukin-10 by doing an extracorporeal therapy. So if patients need dialysis, we prefer high flux dialysis. But the significant value in mortality has not been confirmed in these patients. The endothelial damage needs anticoagulation to stop thrombosis by heparin or enoxaparin. Prostacyclin has been used successfully in small series, and antioxidants have been suggested without confirmed outcomes so far. There are direct viral drugs. I'm not in a position to discuss all of them, but that is the cycle that we all know. The virus attaches itself to COVID, ACE2. It goes inside the cell. The cell lysosomes break it into the RNA. The RNA will reproduce the virus, and that produces the machinery of the cell to produce more RNA, and then it sheds out of the cell. And the drug targets that we know are located in all these areas. Monoclonal antibodies of convalescent plasma will coat the virus, neutralizing antibodies, so you hide the spike protein. Chloroquine, I mentioned it, and I would like to add that the breakdown of the virus itself in order to clear the RNA is inhibited by chloroquine because it raises the pH inside the protease vesicles. Reproduction of the virus can be stopped by remdesivir or flaviprevir, which inhibits the RNA-dependent RSN polymerase, which is the essential enzyme here. So I have many of them. But let us see them one by one. This is effective. Chloroquine is not effective. The anti-HIV combination is not effective. The faviprevir is not effective. Remdesivir is apparently effective. These are the ineffective one. This one seems to be effective. This is a very recently published comparison about mortality. Remdesivir versus placebo, there is about 5–7% difference in mortality in favor of using this drug. And that is overall, there are specific endpoints in this study, but generally this is one of the very early outcomes that came out of antiviral drugs. Another drug that is very interesting to me in particular, which is the camostat mesylate. This drug acts on the modulating system here, which attaches the TMF-SSS2 that makes the virus attach to the ACE2. It inhibits this attachment. So probably it's going to be as effective as the convalescent plasma or even more. It is under clinical trial and we don't have results yet, although there are preliminary data from Southeast Asia which suggests that it will work. So there is some hope, but we don't have really good antiviral drugs that affect this. Of course, I might say that don't forget, please, that we are nephrologists. We have to continue treating our patients with stages 3 and 4 CKD. Dialysis patients, we have to maintain their schedules, standard screening, isolate suspected cases. Transplant patients, minimize immunosuppression, and mind the drug-drug interactions which happen with antiviral agents. So, Mr. Chairman and ladies and gentlemen, I may conclude that the kidney is subject to significant injury in COVID-19. Proteinuria, hematuria, and AKI are the main manifestations. Proximal tubular isometric vacuolation, interstitial inflammation, thrombosis, and focal segmental sclerosis are the main histological findings. Kidney injury is multifactorial, including systemic hemodynamic perturbation, ACE-ACE2 imbalance, massive cytokine release, endothelial injury, capillary thrombosis, multi-organ crosstalk, and direct viral invasion of the proximal tubules and the podocytes. Management must address all mentioned pathogenic factors, and prognosis is poor, particularly in the presence of CKD, comorbidities, dialysis, and transplantation. Thank you very much. I'm sorry for taking much of your time.
Thank you very much. It is a fascinating presentation, and it is full of many useful data. I know that the discussion will be very hot, but let me to start by a point regarding hydroxychloroquine and chloroquine. There is a very nice article in the Lancet showing harm with the use of chloroquine and hydroxychloroquine. It is observational study, but confirms the harm of hydroxychloroquine and chloroquine. And another article in the British Medical Journal, it is open label randomized controlled study showing no benefit of hydroxychloroquine. And I reviewed the issue of prophylaxis because since many weeks, we are devoted for using chloroquine for the medical staff. And I found the big data coming from observational study from Tel Aviv showing no benefit, no difference in infection rate among healthcare workers taking prophylaxis or not. I have one question regarding aspirin. Is there any role of aspirin, or if we should use anticoagulation, as you mentioned, dear Prof?
Yes. Well, and regarding the hydroxyquinoline, I completely concur. I may like to add as well that prophylaxis was used extensively as a routine in England.
Yes.
And after treating 300,000 patients, they abandoned it and found that there is no difference again. So I think everybody is convinced that hydroxychloroquine is useless, although the French Professor Raoul continues to argue that it is very helpful. And of course, the Egyptian guidelines, as you know, until only 2 or 3 days ago, insisted on giving hydroxyquinoline to everybody. And I think that we have seen some sudden deaths in people in this country, very unexpected. I think they are all QT syndromes. So at the end of the day, happily, we have now stopped this practice of not using hydroxyquinoline. Oscar, Tamiflu is equally ineffective, although we insist on putting Tamiflu in our protocols. But that again was abandoned 2 or 3 days ago. So thank you for supporting the concept that hydroxyquinoline is not useful. And that's it.
Aspirin. Yes.
The theory is it should be very useful because you have a TMA and you have an endothelial injury, and small dose aspirin will increase the prostacyclin in the capillary wall, and it should work. But whether there is a controlled study of aspirin in COVID, I'm not aware of any. Yes. But if somebody is taking aspirin, particularly those who are taking it prophylactically for heart disease or stroke or whatever, I think they should continue.
Yes,
I
okay.
don't know.
Regarding plasmapheresis, is there any role for plasmapheresis in treating severe COVID-associated ARDS or cytokine storm?
It was suggested by
Yes.
some authors, but I think the harm proved to be more than good because you immunosuppress these patients by removing immunoglobulins, if there are any. You know that by day 10, you start to form IgM, and by day 14, you start to form IgG. And that is the hope of the patient to recover. If you go on and plasmapherese these patients and remove these antibodies, I think you are doing much more harm than good. For the TMA associated, it's not only a TMA, there is also a DIC. There are both. There is activation of the coagulation cascade as well as endothelial injury. So I think that if you focus only on the TMA by doing plasmapheresis, you probably are doing more harm than good. I do not recommend it.
Okay.
And I'm not aware of any controlled trial about it.
It is just case reports, but I am not convinced by the role of plasma exchange. The IVIG, is there any role for IVIG?
Yes and no. IVIG may accidentally provide immunoglobulins that are useful. It can have this non-specific effect of coating the antigen-presenting cells and so on, maybe. But what has been tried is the convalescent sera from patients who recovered rather than the non-specific effect of IVIG.
Is there any problem of using ASA therapy, or there is ASA resistance in the presence of excessive inflammation with COVID-19? This is one of the questions on the chat. Yes, erythropoietin or erythropoiesis agents.
ESA. Oh, sorry. Yeah. Using erythropoietin.
Yes, because there is a proposed inflammation and proposed resistance.
Yes, and will increase the chance of thrombosis. So no.
Okay. The last point that we discussed was Professor Hussein Sheashaa yesterday about the restart of transplantation program, because we stopped here the transplantation at Urology and Referral Center, Mansoura University, since 11th of March. And we're discussing this issue this week. I want to start and what are the prerequisites, and I want to hear from you, your opinion, and then to hear from Dr. Faisal Shaheen, his opinion about this point, because he is contacted with the authorities of organ donation everywhere.
Okay, we also stopped transplantation even before that, by the end of February, because we had a long Zoom meeting also that with our team, and we decided that there are too many risks for the donor and the recipient, and we stopped, I think, by the 3rd or 4th week of February. And then the team started to argue now, saying, why don't we go back? I personally feel that when we stopped it, there were only 700 patients in Egypt with COVID. Now we have 20,000. Is this the right time to open? I feel that it's too premature. But I don't know. Nobody knows. But I think the rationale that we used in February to stop transplantation still holds today, multiplied 20-fold. So what is new to change anything that you have decided in February? I don't think we should. But I'm very open to hear other points of view.
Dr. Faisal, unmute, yes. Yes, Dr. Faisal.
Thank you, Prof. Rashad. I enjoy very much your talk, and especially in the transplant sections. And I may add something about the statistics you have, because I'm involved in a committee worldwide about the transplantations. And for sure, the transplantation being affected very seriously, and it's come down to a drop to 80% and 90% on some country. But the good thing is that all the countries start to begin again to have a good transplantation service. Even USA, the curve you have it, probably it's the 1 month back.
Yes.
But for the last week, they returned back again, probably to the basic or even more than the previous one. In Italy, they have dramatically up to 0 donor. Now they have a good donor, and they have even better than before. The donors rate is high. In Spain, it's come down 80% and now returned back to normal again. And the questions which Prof. Hussein mentioned about how to start and think, I think the people going to start again, even if they have some sort of donor risk. In Spain, they have around 26% of their donor being affected by COVID, but the mortality was not high. So they decide to continue doing transplantation from deceased and now start again from living, not only in Spain, Italy, Austria, and USA. UNOS statistics show that even the living related start to pick up again and from the last week. So I know that your concern is the same like my concern. In Saudi Arabia, we have only 3 centers which is still working with the deceased donors and living very minimal case. But I think we have to think now to restart the wheel again, because we don't know when COVID will go. Maybe it will stay with us for a long time. So I would not like even to think that we will stop our activities because of the COVID, and then we can hold the system for years and the patient is dying waiting for organs. Thank you.
Yeah.
So
I have a little bit of concern still, Faisal, that these countries opened up when new cases dropped almost to 0 or to the safe 5% level, which is usually taken as a good sign. When you have a growth of numbers of infected patients that is less than 5%, then the chances of spreading the infection are less. In our country here, we still have a very, very high proportional increase. Yesterday or the day before, we had 800 new patients. Yesterday, we had 1,200. So the number of patients, the proportion of patients who have new infection is still too high compared to the declining figures in Italy and Spain and the US and so on. So I wouldn't compare our situation with the countries that have opened up. I think we need to wait a little bit more. And I have listened to a presentation by the Minister of Higher Education who used some curves and so on to show us that we will reach this level of less than 5% increment in the new patients by, I think, mid-June or so. So if we do that, then mid-June would be the right time to start discussing coming back to the process. I don't know. I really don't know.
I agree, Prof. I agree exactly what you said. They wait till the curve start to come down. And when it's come down, but not to 0 or to 5-10%, once it's come down, the recovery of the patient is more and the mortality is less. They started to reopen again.
Thank you, Dr. Faisal. So we speak about US, so we want to hear from Professor Amr Al-Husseini and Dr. Nadine Barsoum about the experience in the United States. Dr. Amr.
Yeah, thank you so much. Thanks, Dr. Rashad, for your great presentation as usual. That's very expected from you. So yeah, in the United States, depends on the place that use of the problem is.
Okay.
Can't you?
Yes.
Can you hear me or not?
I can hear you.
Yes, I mute myself.
Okay. Okay. So yeah, it depends on the program and the place of the program. Here in Kentucky, we resumed both our disease donor and the living donor transplant program, but in other places with higher either. It depends. It mainly depends on the spread of infection. And we here in Kentucky, we flattened the curve already. So we are testing both the donor and the recipient twice to make sure that both are negative before proceeding with the surgery.
I think it is a good practice. Dr. Nadine, just a moment to unmute Dr. Nadine. Yes, Dr. Nadine. Unmute. Okay, until Dr. Nadine with us, we start with Dr. Kamal Aukasha. Dr. Kamal. Yes, Dr. Kamal. اضغط على الانميوت يا دكتور كمال. Yes, دكتور كمال. Yes.
Can you hear me?
Yes, دكتور كمال يلا اتفضل.
Thank you very much, dear Professor Rashad Barsoum, for this elegant presentation, which really clarified a lot of mystery regarding the COVID-19 and kidney. My question, for the sake of the time,
Yes.
regarding the issue of hydroxychloroquine again. In our meeting, actually, all speakers just recommended to discontinue hydroxychloroquine. And in actual fact, in our recommendation, it's still one of the very common medicine in our protocol in Egypt. But instead of just discontinuing because of inefficacy, what do you think if we just combine with other medications, or whatever, either antiviral drugs or one of the newer medication that has been used for another issue like antiparasitic treatment, for example, ivermectin and nitazoxanide and other medications that we just heard every day. So this is the first question. Second one, role of steroid in different stages of COVID-19, either on the lung or the kidney. And last one, the camostat mishylase. There is any, potential result for this drug? Thank you very much.
Thank you, Professor Kamal. Your first question is about combining hydroxychloroquine with other antiviral drugs or antiparasitic drugs. Of course, I don't know. Yes. I don't think the combination that everybody has used is azithromycin with hydroxychloroquine. That is the standard that the President of the United States is using. But I don't think this is enough evidence that we should be using as well. The problem is that when you combine hydroxychloroquine with azithromycin, you increase the cardiac system. Yes. You increase the QT prolongation. And therefore, the risk that frightens everyone is even magnified. Azithromycin is being used, A, because it combats many of the respiratory infections, and B, because it may have some antiviral effect. Nevertheless, I think the balance of using this combination versus its risk is not very favorable to this particular combination. But there are other combinations of hydroxychloroquine with other antibiotics, like quinolones, for instance, which avoids this additional risk of azithromycin. But again, it becomes only prophylaxis against bacterial infection, which is a secondary issue that should depend on the kind of secondary infection. So combination with antibiotics has its rules. Combination with antivirals has to be tried. I don't know. But it makes a lot of sense if you combine two steps in the process of viral replication. If you use something that affects the pH of the protease and something else which inhibits the polymerase, for instance, then probably you can get better result. But what is happening with the drug-drug interactions, what can happen with toxicity, I have absolutely no idea. It has to be tried on animals and then humans and so on.
There is a phase 2 study nowadays on the combination of lopinavir, ritonavir with interferon beta.
Yes, that is true, but not chloroquine.
Yes, not chloroquine. Dr. Nabil Hassan. Dr. Nabil, we have a question from Dr. Amr, but we will start with Dr. Nabil. Dr. Nabil, اتفضل.
Thank you, Dr. Rashad, for this marvelous talk about COVID-2. And we are flooded with a lot of medications. And I think many of the questions have been asked about the use of aspirin, hydroxychloroquine, and many others. I think you have covered the subject very well, and I have no particular question.
Okay.
Thank you very much.
This is an honor to hear this from you, Dr. Nabil. Thank you.
So Dr. May Hasaballah is with us now. Dr. May.
ازيك يا مي؟
أنا مش عاوز استجيب للانميوت.
طب نعمل ايه؟
دكتور عمرو we'll take question from Dr. عمرو حسين.
هنسمعها مي.
Yes, دكتورة مي. علي صوتك. علي صوتك وقربي من المايك يا دكتورة مي.
I've been trying to log in for an hour or so.
Yeah.
It's good to see you.
Yes, always good to see you, Dr. Rashad.
Good to see
I have a comment on the transplantation. I think
Yes.
that the patients going to dialysis, they already are exposed to infection. And by doing transplantation, provided that you test for the virus before from the patient and the recipient twice, and you're sure they're negative, and then the patient is going to be locked at home anyways, I think this is not a bad idea, in spite of the fact that we have this. I mean, in dialysis also, there is this possibility, a big possibility of infection and exposure. So I think each case has to be discussed separately, and depending on if the patient has a problem with the fistula, or if the patient has a problem with the donor, if this is a preemptive transplantation, things like that, I think it can be taken each case by itself. I don't know what you think.
I completely agree that even when we decided to stop, we didn't exclude emergency transplantation. For, as you say, a patient whose fistula is gone, and the choice is between dying of under dialysis or risking contracting an infection with COVID. So yes, I completely agree that emergency transplantation can be performed. But my concern is not locking up the patient at home. It's the period during the patient's stay in the hospital, where the hospital is a focus, where you can get any patient who gets infected, any nurse, anybody. So I thought that if it is elective enough, it has to wait. If it is not, then we have to take the risk. But I concur. I agree.
Okay.
وعمري على فكرة مختلف معاك يا مي. Whenever you say something,
we'll take question from Dr. عمرو. I am postponing with Dr. الفيشاوي and Dr. Mohammed Saeed to the end, because I know that Dr. الفيشاوي has a lot of points because he shared in the guidelines, the Egyptian guidelines. So Dr. Amr.
So Dr. Rashad, do you agree with me that the only medication so far that has been approved by the FDA is the remdesivir, despite that remdesivir didn't improve, significantly, at least the survival? It's only decreased the severity and the duration of the disease, I think from 15 days to 11 days or so. So despite that, we are flooded with this all kind of medication. So far, we don't have approved or evidence to use any of these medications, except retrospective small studies. But this study on remdesivir was NIH-sponsored study on more than 1,000 of patients. Was controlled randomized trial, and still this is the only, I think, good evidence we have. Then I have other couple of questions regarding dialysis.
Okay.
Do you recommend starting or
Dr. Amr, let us to take it one by one. So remdesivir, Dr. Rashad.
I agree completely with the statement of Dr. Amr that the FDA and the CDC approve compassionately the use of convalescent plasma, and they approve in the Cytokine Storm to use anti-interleukin 6, but antiviral only remdesivir, as well as being very cautious in accepting it for the reasons Dr. Amr mentioned. I may add that the trials did not include patients with renal failure. So we are not sure if remdesivir is going to work in our patients, or could be toxic to our patients, or could interact with a drug that we use in transplantation. So there are lots of question marks about this drug. Yet it is mentioned because it is the faint light in the very big tunnel. So we have to see it in order to have some hope for the future.
Okay, Dr. Amri, yes.
In a cohort of 89 patients in our hospitals that we studied, patients who developed the acute kidney injury and required dialysis, 80% of them died. So it seems that the mortality for COVID-19 patients who require dialysis, patient with severe AKI, the mortality is very high. And I remember there was a conversation, in some of New York hospital, do you really need to dialyze these patients or not? Because
they die anyway.
They're going to die. Right. And the other thing, they might spread the infection, especially they will need CRRT, the slow continuous therapy, and the nurses and healthcare provider going on and, in and out in the room, they might spread the infection more. My question for you, sir, do you recommend any kind of dialysis, either intermittent or slow renal replacement therapy? This is number one. Number two, timing of dialysis. Do you like earlier, or is there any data in favor of earlier or later, dialysis? And the last one, I'm sorry to take I just want to hear you. So the last one, the FDA, when it comes for approval, the FDA also approved a filter, a CRRT filter called, Xeris, that can remove the pro-inflammatory cytokines. But I'm now worried when you mentioned about the benefits also of these cytokines, because this filter, I think, can remove both the pro-inflammatory and the good cytokines. What's your intake on that?
Starting with whether to dialyze these patients or not, your number of 80% mortality matches with the rest of the world, the 75% in China, 75% in different other studies. So yes, 4/5 of these patients will die. But I would still dialyze them because there is a chance of 20% of patients, if you have the setup, a very careful setup for isolated zone or room or part in the ICU that is only for COVID patients and so on. I really don't have the guts of leaving 20% to die because 80% are going to die. So I would say yes. The modality, I think there is no clear evidence that continuous replacement therapy, it's like CRRT in anything, in sepsis, in anything. You feel it's useful, but when you don't conduct a study, you don't get a positive result. That has always been the case. I am convinced that patients with septic shock, for instance, benefit a lot from CRRT, but you don't find a controlled randomized trial saying this. Conclusion, yes, I would love to put them on CRRT.
Early or late?
Early or late, timing?
Late, because there have been lots of arguments about exposing the blood of these patients to dialysis or to membrane oxygenators would increase complement activation, or even with a very biocompatible membrane. And that can lead to exaggeration of the inflammatory process. So the recommendation is to wait until you really need it. The argument that, which I mentioned also, that when you remove interleukin-6, you also remove interleukin-10, which we don't like to do. You want interleukin-10 to stay. That there are trials, I think, from Austria, where you use microcapsules that you put them into a secondary circle that have affinity to a particular cytokine. So you remove interleukin-6 only. You don't remove 1, you don't remove 2, you don't remove anything else. And that is a useful thing to do, but it has never been used commercially or available everywhere. It's only research, which I find useful. And finally, adsorption columns can also help in that because you can be selective in what you can remove. So long as we want to remove cytokines, we have to be selective. We can't just put everything together in the same basket.
So if we put this in the context, this means that you don't prefer medium cutoff membrane or expanded dialysis by using filters that get rid of these cytokines?
I am in favor of using CRRT, but
yes.
No specific membranes so far.
Okay, okay. Dr. Hussein Sheashaa.
Thank you, Dr. Hussein, for this really excellent webinar. I want to thank my dear Professor Dr. Rashad Barsoum for this excellent and pioneer, of course, and elegant talk. I have learned from you, as usual, a lot of pathogenesis, and a lot of mysteries have been solved by this excellent presentation. Really, for the time factor, I want to ask hundreds of questions, but for the time factor,
200
for the sake of Dr. Hussein Sheashaa help not to lie from me.
زين احنا بنكلم بعض كل يوم بس ارهمني مرة
please, I will ask questions.
One question.
Please give me 3 or 4 questions.
طيب اوكي.
The first question for my dear Professor Rashad Barsoum.
واحد يا حسين عشان ما ننساهمش.
Okay, واحد. I am concerned about the pathogenesis. As we know that COVID-19 is characterized by severe lymphopenia. This severe lymphopenia, the first question, if there is explanation for this severe lymphopenia. The second question in this issue, as we know that the cytokine storm usually started from the lymphocytes by the release of the interleukin-6 and the interleukin-1 and others. How can, with this severe lymphopenia, that can generate this cytokine storm? And as we know very well that they have found that the comorbidity and mortality is associated, and the severity of the disease is associated with the severity of lymphopenia. How it comes that with more severe lymphopenia, we have more cytokine storm and we have a higher mortality rate, and they have found that a high percentage of the COVID-19 infected personnel have died from the cytokine storms.
Okay. Professor Rashad.
Okay. The T lymphocyte is one of the targets of the virus, although it does not replicate in the lymphocytes, but it affects the lymphocyte. So it is a diseased cell that eventually dies with apoptosis. And since we know that if you count the lymphocytes in the peripheral blood, about 90% are T lymphocytes and the rest are Bs. So if you expose the major population of the lymphocytes, which are the T, to a virus that induces apoptosis in these cells, then it is clear that they will decline very rapidly and you get a very low count. How does this lead to an increase in cytokine production? It's because the cytokines are produced by more cells, by more than T cells. B cells can produce them, monocytes can produce them, the macrophages can produce them. So eventually you still have other factories that produce these cells, but وانت عارف انه the capacity of T lymphocytes to secrete cytokines without dying is limited. They tend هم عاملين زي العساكر يلتحموا وينتحروا ويطلعوا cytokines. لكن البي lymphocytes دي مدافع تضرب من بعيد without dying. So you spare B lymphocytes and kill T lymphocytes, and while they die, they secrete cytokine. I don't think see
seems, Dr. Rashad, if you allow me, it seems that the cytokine, the main source is from innate immunity rather than lymphocytes. This is why there is a hypothesis in transplantation. If there is lymphopenia induced by immune suppressive drug, this is maybe protective, but I'm not convinced by this hypothesis that was written in American Journal of Transplantation. So at the end of the day, all cells they can share in the cytokine storm. Second question, Dr. Hussein.
Yes, the second question. The second question, I have 2 comments. The first comment, I agree totally with you, Professor Dr. Rashad, that we should postpone the transplantation program. And here in the Ministry of Health, we have recommended that transplantation should be postponed in spite if we have طبعا emergency such as absent vascular accident and others, we should go for transplantation. But there is a strong issue that are arguing with us, and I know that your point that we are now in the peak and the peak may increase later on and the numbers are increasing, while other countries the curve is flattening or declining. But really we are confronted by a lot of debate for postponing the transplantation program, that the dialysis patient, I have mentioned Dr. Saballah, that they are going to dialysis centers, exposing to the reception, to the security men, to the nurses, to the doctors, to other patients. And with in our country, really, we have no proper issues for proper, of course, protecting our dialysis patients, so that they are also have higher incidence.
So Dr. Hussein, so this is a broad
to get infected with from other contacts. While transplantation, it will be only 1 week inside the hospital and it can be in home. This is an issue for debate.
I think for dialysis, if the patient has residual kidney function and there is urine volume, we may adopt the policy of decreasing the frequency of dialysis. Although there are some cons about twice sessions per week, but if the patient is fit with residual urine volume, no metabolic decompensation, I prefer to decrease dialysis frequency rather than thinking of transplantation in rushing way. In kidney transplantation, it is completely
not rushing way.
Yes, yes. So do you
yes, I mean that still in Egypt, we haven't adequate protective measures, so that we have a lot of infections in dialysis patients now in Egypt, so that this is the conflict, to go for transplantation with the risk of course, infecting with the virus, but with a short period, just 1 week in a hospital, or leaving the patient. And it seems that this problem may take several months, that leaving the patients to go to dialysis units, and they have a higher risk to be infected according their way inside the dialysis unit. This is the second. Yes. The third question, sir, about the timing of dialysis.
Dr. Hussein.
Thank you. The third question for Dr. Rashad, or
the last
I want to hear from you. The last one. Yes. That I have one. This is before the last. That dialysis in
حاول تكلفته وما ينفعش.
ما ينفعش لا ما يقدرش يضحك عليا. This question, what I mean in this question, that dialysis in, of course, of dialysis patient, I agree totally with Professor Rashad that we can use immune absorption membranes that can absorb interleukin-6 and the harmful cytokines, but we shouldn't, of course, we should, of course, mention that they have found that when you are removing the cytokines in the cytokine storm, here you have more and more harmful cytokines. So in this situation, even if you have removed both the cytokines, which are harmful cytokines, such as interleukin-2, 6, and interferon gamma, and just leaving interleukin-10, which is protective, here you are removing more towards the harmful cytokines, so that here the CRRT with high flux membrane and removing of this harmful cytokine in this situation may be beneficial, because here the trend is towards the harm cytokines and not the benefit. The second issue, starting early from late dialysis, I think that if we have no adequate isolation, we should of course delay the dialysis, not to infect others and doctors and nurses, but of course if you have a proper isolation centers, I think that early dialysis, as in sepsis, here may play a role to decrease mortality rate. And I fear, because most of the studies have mentioned that the mortality rate was high because they have, of course, late dialysis. I think that if we have adopted the proper protection criteria and we start early dialysis, here we may improve the, of course, mortality rate. I'm not sure.
Thank you, Dr. Hussein. Dr. Rashad, please.
The third question, I'm sorry, the last question.
Dr. Hussein.
Last question, Dr. Hussein, bas. The last question. I want to ask a philosophical question, Dr. Rashad. Do you think that the virus doesn't infect patients only? It hasn't also infected the strategies of our scientific approach in medicine, such as what had happened in chloroquine and others, and we have no peer review, of course, in articles such as Lancet, New England Journal of Medicine, and others. I want to hear from you, dear Professor Rashad.
Infected the system, you say, the paper submission system, for example.
Yes.
Yes, there are sequelae, of course, and I can quote two examples. One, that FDA is now approving drugs with very much less stringent criteria than usual. They don't ask for details of the studies. They declared that they, for the sake of rapid discovery of a drug that can affect the virus, they are not going to be very stringent. But I'm sure this is temporary. I assure you that by the end of the whole epidemic, eventually everything is going back to the usual criteria of selecting, approving drugs and all that. That will happen. That is one thing. The second thing is that we are seeing much more observation studies than RCTs today, because there is no time for designing an RCT and there is no room for controlled trials. So we have to accept تنازلات in accepting drugs and so on. But I don't think this will last. I think this will only give us a model that in crisis, we can be flexible and we can accept reasonable evidence rather than absolute evidence for accepting things.
Okay.
That is the philosophy about it, I think.
Dr. Mohammed Saeed.
First of all, I would like to thank Professor Rashad Barsoum for this very elegant lecture. And actually, all of us in the nephrology community in Egypt, we are proud to have shown any Egyptian nephrologist go outside or abroad. Once he says that he is from Egypt, Professor Rashad is on the top. Thank you so much, Professor Rashad.
Thank you.
My point regarding what you mentioned in the lecture about the AKI in COVID-19 patients critically ill in the ICU, I think we have to consider them completely different from any type of AKI secondary to bacterial or other type of viral pneumonia. Because of the higher mortality rate in this kind of patients, once the creatinine is rising, the mortality rate is high. We saw many patients, male, I'm not sure why male, morbidly obese, diabetic, hypertensive. Once the creatinine 1.5, 1.6, within a few hours intubated, hypotensive, and they die. So we shouldn't, I think, in my opinion, we shouldn't apply the same definition and classification system for AKI for traditional causes of AKI in COVID-19 era. Because if we'll wait until the kidney touch or the creatinine is rising, we are already late. So once the patient is high risk and he's critically ill and in the ICU, I think nephrology consultation is priority. Because if we will wait until the creatinine is increasing, we will lose the life of the patient. So I think, what do you think about a critical care team, including a nephrologist, as you mentioned, on the top? This is my first comment.
As you rightly mentioned, in the introduction to my talk, I thought this would be the message that the kidney is an important target in this disease, and therefore a nephrologist has to be in the team, but not on top of the team.
Yeah,
just in the
and the definition and classification for traditional cause of AKI, do you think that we have to change it or use it carefully in COVID-19 AKI? We'll wait until...
I think the definition can stay because the definition tells you that you call it AKI according to urine criteria and creatinine criteria and so on. That is classification. But what has to change is the threshold for dialysis. Within the same classification, there are criteria, severity scores, mortality scores, and so on. These have to be modified in order to accommodate the clinical picture of COVID. Not only because the lung is also involved, or because hypoxia is a dominating feature everywhere, but because the heart is almost invariably also affected, and the chances of having brain injuries, starting with the taste and olfaction, but strokes are increased and so on. So I agree completely that we should be ready to modify our dialysis criteria or RRT criteria rather than the classification itself.
Yeah, the second point regarding the COVID-19 is nothing other than thromboinflammation, thrombosis and inflammation. What do you think about the accurate or the right dose of anticoagulation like Clexane, what we are using currently? Do we have to rethink about the dose to upgrade or stratify our patient regarding, because many patients in the autopsy, as you mentioned, in the kidney and in the lung, they have microthrombosis, they have micro showers. So what do you think about the issue of anticoagulation doses in the ICU? Is it subtherapeutic in COVID-19, or we have to think to upgrade it a little bit?
Well, I'll tell you what I see as logic. I don't have an answer based on trials or comparisons or even observation studies. But as you say, since thrombosis is the way people die, then we have to address thrombosis and anticoagulation more aggressively. However, many of these patients have lung infarcts already and they develop hemoptysis, in which case adding more anticoagulation will make them bleed more into the chest. And those who have GI involvement can bleed from the gut. And those who are in shock can develop stress ulcers in the stomach. So there is always the risk of over anticoagulating. What I would recommend, without referring to literature, is let us do anticoagulation on under control of APTT, because if there is a thrombotic tendency, then if you do an APTT, you will need more heparin in order to achieve a therapeutic level of APTT, which we don't do anymore because we think we know the doses. But I agree with you that it could be included in the protocol that COVID patients should receive anticoagulation with a target APTT rather than a fixed dose therapy.
If you allow me, Professor Rashad, APTT will be protective to use the drug safely, but there is a very nice algorithm based on the dimer. According to the level of the dimer, even we decide the type of anticoagulation, duration of anticoagulation. The higher the dimer is, the more the prolonged course, even after a cure of COVID and the patient discharged to continue, if there is the high dimer and thrombosis. So what's your opinion about the use of the dimer?
The dimer is the outcome of the process.
Yes.
But when you want to adjust the dose, say instead of giving 50 milligrams, you need 60.
Yes.
The dimer will not tell you. If you want to titrate, there has to be a number for titration, and that will not be a dimer.
Okay.
And if there is a clot somewhere, then it will release the dimer in itself, regardless of how much you give of heparin. So I think heparin, when I started dialysis, when I was, انت قلت اتولدت سنة كام؟
أنا 68.
طيب أنا سنة 68 دي كنت عملت dialysis to hundreds of patients. At that time, we didn't have a fixed dose anticoagulation. كنا بندي هيبارين وناخد، او كنت بعمل الاي بي تي تي في الاوضه الدايلسيس جنب العيان، واقول هدي له همسه زياده، احط له شويه قليل انسان. الناو بقى انت اتولدت في العز وعارف بقى ازاي ندوا.
اوكي شكرا.
اخر حاجه تروح حسين، اخر نقطه صغيره.
احنا we have excuse me دكتور محمد, we have 5 minutes and to close this webinar. So if you allow me to have just Dr. Saeed Khamis and other questions.
اتفضل.
Yes, because the time is we are racing against time, and I don't like to exhaust Professor Rashad more than this. Dr.
I'm
Saeed.
enjoying your company. بجد يعني I'm enjoying it. Thank you.
Thank you, Professor Rashad. Thank you so much.
Thank you.
Dr. Saeed, تفضل.
Yes, sir. Good evening, sir. Thanks, great professor, for this elegant lecture. As usual, just I want to one comment and 2 short questions. What the comment is, do you think, sir, that I think the mortality and morbidity of this COVID-19 crisis, later on we can discover or see that more than 1/3 of the patients, I think, died or affected because of this iatrogenic effect of medication or intervention. That's number 1. Number 2, what about colchicine? I think there was one trial in Canada. And the third is, what about ECMO, this extracorporeal membrane oxygenation? And the last question regarding the hypertension. Why mortality is high in hypertension, in hypertensive patient with COVID, despite if the patient has no cardiovascular complication and still hypertension is a risk factor for mortality? How the pathogenesis of this issue?
Okay.
Thank you, sir.
The first point, compassionate use of drugs and associated mortality and iatrogenic death.
Can it increase mortality? It can, of course. I'm not sure. It's very difficult to speculate because it is presumable that once you permit the use of a drug, you know most of the pre-marketing side effects, but every drug will have a chance post-marketing. And I must say also that we will get approved drugs without knowing exactly what they do in the ambience of renal failure, because the interaction with middle molecules, interaction with electrolytes, and so on, can be completely ignored until we use the drug. So you may be quite right. You said 30%. I'm not sure, 30, 40, 20, 10. It depends on which drugs we're going to use. But we have to be cautious and aware of this.
So repurposing the drugs is not 100% safe.
Yes.
Yes.
I need also to add that AKI in general, regardless the cause, is known to leave residual effects in quite a large number of patients due to any cause. Now that we know that with COVID, the damage of the kidney is basically done by chemicals which increase fibrosis, like angiotensin, and also by inflammation in the interstitial tissues, which can end up by fibrosis. It is very likely that at the end of the day, when patients recover from KI due to COVID, we will meet in a few years a chronic disease, in addition to the collapsing glomerulopathy and the viral injury of the tubule. We can have in a few years a disease called chronic COVID nephropathy, which we don't know yet. We have to treat many acute patients and see what will end up. That is regarding the question of side effects. The second question was?
Colchicine.
Colchicine is theoretically useful as an anti-fibrotic drug, but I am not aware of outcomes of any studies that have used colchicine. I'm not even aware that it is included in one of the ongoing trials. I don't know. Third,
the ECMO, extracorporeal oxygenation.
As I mentioned, some patients need ECMO because of their pulmonary condition, but there are reports that it can increase complement by exposure to the cellophane and increase the inflammatory process at large. So this treatment may improve hypoxia, but it will also probably increase the damage to tissues by associated fibrosis.
The last point, hypertension and mortality.
Yes, I read one paper because I had this same question at one point. Why are hypertensive patients? Why is hypertension per se an independent risk factor in COVID? And the answer I found in a paper of Ohda Arrawi is that in hypertensive patients, T lymphocyte functions are depressed for some reason that nobody knows. But it is an observation. And therefore, you start with an advanced injury in the T lymphocytes, so you get more leukopenia and more viral injury. مش أنا اللي قايل كده، لكن ده اللي قريته.
I want to just يعني بعتذر لكل الناس اللي مش هنقدر نخليهم يسألوا. the last point ما انا عاوز حضرتك بقى دكتور رشاد to conclude this webinar بحيث حضرتك تبقى الفاينل speech.
Thank you very much, Hussein, for leading this session so well. And I thank the audience very much for being tolerant to exceeding my time, but you encouraged me to increase my time to explain the points more elaborately, because there are issues that cannot be taken lightly. So I thank them for their tolerance. I thank them very much for the comments and for the nice words they said about me and for the very rational questions that were made. And the final outcome is that we are entering a new era in nephrology, a disease that was not in our books. And we are learning this disease from experience. We are so fortunate to build up the knowledge about a new disease in our own lives and not from a book. We are writing the book. So we have all the time to record our data, publish, and be part of the new scenario of COVID nephropathy, call it acute COVID nephropathy, chronic COVID nephropathy. Nobody has the advantage more than us. So I encourage everyone to publish. Everybody has 10 patients, they just publish. The publications that have been done in top journals, New England Journal of Medicine, Lancet, are so soft these days that you can write anything. It will be published. So let us share in the international community of learning about this deadly condition.
The last point, would you please, this is the question from all the audience in the webinar and everywhere. We want a promise from Professor Rashad Barsoum to meet again, even after a period of time, because today you learned a lot from your master teaching. So please, we want another time for a scheduling for the coming webinar with us.
أحلى أوقات حياتي هي إني أحاضر مع زملائي ومع تلاميذي دي أسعد أوقات.
يعني
لو ربنا اداني العمر واداني الصحة
إن شاء الله يديك.
إن شاء الله.
إن شاء الله يعني إحنا باسم الناس كلها اللي موجودين وباسم الناس كلها اللي هتسمع الفيديو يعني no words يعني توصل احاسيسنا والابريشيشن، وان شاء الله هكونتاكت حضرتك بعد شهر لتحديد موعد اخر ان شاء الله. ان شاء الله. شكرا جزيلا وتصبحوا على خير. مع الف سلامه. مع سلامه الله. مع السلامه.
شكرا.